record. Okay, so hello everybody, welcome to Pain Geeks, the book club. Today we're going to be finishing off the series of books by Louis Gifford, Aches and Pains, and we're going to be looking at Graded Exposure, which is the third physical book, but obviously there's lots of different topics inside there. So we're going to have a quick look at that today and a reflection on, you know, the content and what it might mean for physiotherapy. And it's really lovely to be joined by Steve Robson, who is a physiotherapist and also was a close friend of Louis and helped to sort of finalize the book alongside Louis. Is that fair to say, Steve?
Yeah, so I kind of proofread most of the books along with Mick Thacker. So Mick and I were, so Louis asked us, so Louis had stopped writing for a few years when he when he was given his cancer diagnosis, and he kind of went off and did lots of things that he loved to do, like fishing and playing golf and going walking and stuff. And then he phoned me up one day and said, started writing again. Would you have a look at some stuff? And I said, yeah, sure. And so he started sending me some stuff up, and we kind of just sending feedback and kind of collaborating from there. So I kind of saw most of it in terms of that. I was fairly busy at the same time, but I kind of dropped some stuff that I was doing in order to kind of to kind of help Louis with the work that he was doing on that. Yeah. So yeah, I was familiar with some of it. Some of it was stuff that Louis and I had touched on, stuff that we'd already kind of worked on, and a familiar thing, and had some just amazing conversations with him really during the sort of the period of him writing the books, in terms of just asking each other questions, and discussions used to go all over the place with Louis in terms of Louis' thinking. It was
I can imagine
very depth and sometimes outside of the box in a great way.
Yeah, absolutely. And I think that so I was introduced to Louis' writing through Topical Issues in Pain before this book came out.
Yeah, great series. Yeah,
I mean it's and I've got one of them here just in case no one's ever seen them, and it's a series of, I think it's 5 books, and they're all different colors, like yellow, blue, green, and grey. Yeah. And they all cover a different area of pain. But in this particular book, in the Graded Exposure book, he mentions topical issues in pain for quite a bit, because it talks about pain management and about bringing it all together.
Yep.
But yeah, I think it was the first time I had ever considered like evolution as a way of understanding physiotherapy, or a way of understanding pain. And it was that sort of like, whoa, here we are, way out of what I've just qualified from a basic physiotherapy degree.
Yeah.
And here's this person talking about evolution.
Yeah. And that was a kind of huge thing in sort of both of our thinking. So Darwin was a big figure for Louis and me too. And there was a lovely book written by Randolph Ness, and I'm trying to think somebody else, basically on evolutionary biology and healing, which Louis and I kind of both latched onto kind of way back. And it was, and coming from those examples and stuff that kind of he used and things that I use constantly in clinic, and literally said to somebody this week, okay, if you were a hunter-gatherer and you were a Peruvian Indian living in the Amazon rainforest and you got a bad back, what are you not going to do? Most people get it. Yeah. You're not going to rest. No, because you're going to die. Something's going to eat you, or you're going to die of starvation or thirst. So in terms of thinking about that and how the biology has evolved over millions of years to adapt to the need to have to keep moving for survival. So therefore, obviously, movement is going to be inherent within, and as Louis used to say, the kind of mantra that should be written on our walls is, movement is the forgotten painkiller.
Yeah.
And that's a powerful message. And sometimes, pain's there to make us move, not just to kind of get us to rest. It's obviously there to drive adaptive behaviors, and hence, the mature organism model, the sample scrutinized input output system in terms of that. So yeah, from an evolutionary perspective, really kind of was really important. He'd come from a zoology background, so he originally did a degree in zoology. So biology and the kind of the biological kind of genesis of things was something that was kind of strong in his thinking. And probably the thing that attracted me most. So basically, I read Louis' work on nerve roots many years ago.
Yeah.
some stuff published probably back in the 80s, I think. And, you know, so Louis and I met at a conference and we ended up chatting afterwards. And so the story of sort of my meeting and friendship with Louis, if you like, started chatting after this conference and just throwing some ideas around. And in Louis's lovely way and his lovely Cornish accent, which I'll probably make an attempt to repeat if nobody's ever heard him speak. He just had this absolutely lovely Cornish accent. And he said, yeah, that'll make a really good article, boy. Fancy writing that for this journal that I edit? And I said, look, you know, I'd been involved in research before, but I'd been a data gatherer and I'd never really written up other than doing, you know, dissertations for things like degrees and stuff. And I said, whoa, Louis, you know, I've never done that. Yeah, he said, I'll send you the writer's guidelines. He says, if it's crap, it won't get in. Bloody my reputation as well as yours. In Louis' own inimitable way, and of course it was. So I wrote this article for the journal that he was editing. And it got picked up and people liked it and started asking me if I would write more for stuff. And then Louis kind of asked if I would kind of start doing some stuff with him. And then we kind of started this writing partnership, which kind of lasted, I suppose, for about 50, well, up to his death, really. So we were still writing up until that point. And that was a kind of start of our friendship. But, you know, above and beyond that, I think what he saw in me, I think you mentioned in the, you know, in the Aches and Pains books in the forward was that kind of, we seem to think very much alike. We come from a similar background. We both come from heavily from manual therapy backgrounds and had done manual therapy and seen the kind of, you know, the limitations in terms of that, and kind of started to think above and beyond that. So that was, you know, my initial meeting with Louis. But Louis was just a person with no ego. You know, I was kind of nobody. I didn't have any reputation or anything like that as another writer or anything like that. But he was just interested in people, you know, and that's how I kind of started writing from. I've described it before. It's a little bit like playing for your local football club and then getting a phone call and saying, well, actually, you're going to be playing with Ronaldo for Real Madrid or PSG or wherever he is now in Italy. He's in Italy now, you know, and it was the equivalent of that. But he'd seen something in me and my thinking and stuff that he just liked, and we liked each other as people, and we were very, very similar, really similar actually. Which was the great thing. But as well as being an amazing person, and he was a hard worker and pushed you hard, you know, as a writer and also as an editor. You know, and his famous quote once, if you kind of to get a feel of what Louis was like, it was in the topical issues Pain books, which just reminded me of it when you mentioned it there. I think it's in the 5th one, which is the one after the one that you've just basically held up. We wrote the, I don't know if it was the opening chapter or not, but it was a chapter called Manual Therapy in the 21st Century, which was about basically what the evidence for and against what it couldn't do. And I was kind of writing the neurobiology section on that in the beginning. And I've been living and breathing kind of neurotransmitters and, you know, synaptic connections and cortical processing for weeks. And kind of Louis' big gift, I think, and the gift that he used to kind of, I suppose, kind of bestow on me, which was very generous of him, was an ability to explain really complex things in a very simple way. And he was absolutely superb at doing that and taking really complex biology and kind of making it understandable. And I sent him the draft for that. And I got this email back and he just said, what the fuck is this? And it was because it was just too complex. It was pure neurobiology and I'd been living and steeped in it. And of course, as soon as I sat back and had another look, I thought, yeah, absolutely. And then kind of rewrote it. And then he sent me this lovely little email back because he was obviously the co-author on that chapter and also was the book editor. And he said, thing is, Steve, he says, all editors are bastards. And he says, and all co-authors are lazy bastards. So that was it.
Both then.
But you know, but he was great to work with, wrote hard, expected a lot of himself and kind of other stuff, but just fun, just great fun, and an amazing person to kind of be around and to write with. And everything was fun, even when it was serious. He always basically held that ability to kind of, you know, draw the line between kind of it becoming, you know, too much of a boys' party and drifting off onto other stuff in terms of kind of maintaining focus. What an amazing thing there.
that really comes across in the books as well, though, and you know, it comes across as someone that takes his work very seriously, but not himself, right? So you know, things like drawing on metaphors like the Toblerone chocolate and like numbskulls, and like creating these visual, almost like so you almost have this like it's almost bringing like emotional links into why you would remember this stuff, which is of course like the skill of a great teacher, isn't it? And being able to help people, you know, relate to the information when it's really complex. I mean, I was thinking about the shopping basket approach and just how like it's almost like rewriting what we do in physio. It's like the whole profession, like just sort of taking what we do and then just shunting it so that we can understand it from a much wider perspective in a really simple way.
Yeah, and it's, you know, and absolutely right, because you know, and I've kind of just been writing about some of this stuff as well. It's an interesting thing because, you know, can we always get an accurate diagnosis? And if you know, and I think if you put 10 physios basically, you know, in a room, you've got them all to go and we get lots and lots of different diagnoses depending on when you train, where you train, what your experience has been. But it was kind of a, you know, looking at that and saying, well, does it matter? Well, it absolutely matters if it's red flags, and it's something serious, so we can put that on. But, you know, do we absolutely need to be able to get a definitive diagnosis in terms of that? Well, so, well, look, if we just do what we can do and do it well, of which Louis was a true believer that physios were in a fantastic position to actually help people and help people with pain. Let's take those skills, let's take the examination and the diagnostic skills and use them in a shopping basket approach. Let's look at disabilities and impairments and stuff like that, and I'll get that, right? And then, okay, how can we address them? How can we then change them? Because again, with, you know, with graded exposure, it was, you know, in terms of treatments for pain. Well, what about pain? Well, look, can you do anything? So Louis was a believer in, if you can do something to relieve the pain, do it. But if you can't, continue with the graded exposure. Just continue with that, because ultimately that hopefully is going to change that person's pain and change that person's situation. So it's dealing with what's in front of you and dealing with what you see. So, you know, is it a tennis elbow, or is it some basic, you know, is it some peripheral neurogenic pain? Is it a frozen shoulder, or is it a really irritable nerve root? And you're looking at what you've got and the limitations and that, and just directly treating that. So if we do that, there's a much bigger chance of success, because we're dealing with the stuff that's basically fathomable and the stuff that we can actually assess and measure. And that was the lovely, it was originally published in something called In Touch, which was a journal that goes out to private practitioners who were a member of what used to be the OCPP Organisation of Chartered Physios in Private Practice. I think it's Physio First now. And it was done as a series and that. And I just said to them, you've got to get this into a book. You know, I'd been saying to him for a lot of years. Philip had said, Louis, you need to kind of write a book. And there was discussions kind of way back when. They asked me way back, you know, do you fancy doing some cases? I said, I think you need to do this yourself. It needs to be your book, you know. And I think the shopping basket approach should be in it, mature organism model, because it was just, I think it was too important to be in such a publication that really didn't go to too many people, really too many physios.
Absolutely. Yeah, and I want to really I love the way the shopping basket approach was formed and like the story behind that as well. It's really we'll get into that. I just realized that we sort of launched into discussion and launched into chatting, and I didn't necessarily explain to the people that are with us. So like Gianluca and I'm sure I'm going to say this name wrong. Is it Annie? I think it's a Celtic name perhaps, but it's lovely to have you with us. Thank you very much for joining. If you do want to ask a question, or if you do feel like you want to bring your screen on and be part of the discussion, feel free to turn your cameras on, turn your mics on, and just join us in the discussion. But if you're not feeling that, that's completely fine. You can stay off camera. And if you have a question, please feel free to use the chat box. So the chat box is just at the bottom. And if you want to ask something, just bung it in there and we can try and monitor it and bring your questions through and your comments through. The other thing to say is that if you are a person that uses subtitles, please be aware that there is a subtitling oh, I don't know what the word is, program on Zoom. So down at the bottom, if you press where you see closed captions or CC, you can bring subtitles up onto your page. They're not perfect. It's it's done live, so they're a little bit behind what we're actually speaking. So if you're using it because you're struggling with hearing, then my recommendation is that you turn the sound off completely and use the subtitles. So hopefully that will get better as technology gets better. But yeah, so brilliant. I think that's everything that I need to say. And just to remind everybody that this is going to be recorded and it will be put out across a public YouTube channel so that you know just what you're exposing yourself to. Because sometimes you don't realize it and then you see yourself on YouTube and you're like, oops. Right, so yeah, we have been spending the first two sessions of Pain Geeks looking at the first two books. So we looked at Aches and Pains with Tina Price, who's a pain advocate and a pain ambassador, someone lives with pain, and her response to that book, which was just a lovely conversation, and that's available on YouTube. And then we did The Nervery with Tom Jessen, who's a physiotherapist that's been, I don't know if you've ever heard of Tom Jessen or met him. He's a really early career physio that's just completely absorbed in this sort of sciatica literature, and we had a really, really cool conversation about that, a little bit about where Louis was and maybe what's changed in the time between the book was published and where we are now in the nerve root literature as well, which is quite interesting, and neuropathy literature. So that was a cool talk, so you can access that on YouTube as well, and I'll put the links there. Lovely. So exactly what you were saying, I think, is exactly what I sort of experienced when I read this book. Because I never met Louis. Unfortunately, he passed away before I sort of really found out enough about him really to be able to go to one of his courses, but I think I would have really enjoyed them. And without a doubt, like the sort of models that he's bringing forwards in the books is a big part of how I've designed my practice and how I want to practice with clients and people who are living with pain. So it's had a profound influence, and it's been lovely to go back and read them again, because you sort of forget just how influenced you are, and you're like, oh, that's where I've got it from. And it's not my idea, which is the harder bits. But yeah, coming back to this idea of the evolutionary perspective, and you mentioned earlier that Louis was a zoologist. Do you think that was what made that, because you also are thinking from that evolutionary perspective, but you don't have a background in zoology, so it's something about the evolutionary perspective that he was able to bring, but also that just seems to make sense, that perhaps we haven't really explored as clinicians.
Yeah,
there is a question there somewhere.
Yeah, no, I see where you're going with that, and it's, yeah, and I mean, possibly, I mean, my background was cell biology and genetics, so which basically I kind of studied way back when. I then worked in, I was thankfully incredibly grateful and still are to be employed by two fantastic consultants at the Royal Victoria Infirmary in Newcastle, a guy called Phil Adams, who was a consultant cardiologist, and a guy called Alistair Bruce, who sadly passed away a few years ago, who was a consultant chest physician. And anybody in mainstream medicine will probably recognize Alistair Bruce straight away. He was a world-class teacher, writer, and was responsible for the asthma plan that's in place today in terms of how people manage their asthma. And Alistair Bruce was a massive biopsychosocialist in the days before they even kind of really had a name for it. Yeah. And I worked alongside Alistair for 5 years, and Louis was fascinated with this. I once told this story. Somebody asked me about this at a conference that Louis and I were both speaking at in Glasgow, and I don't think Louis and I had chatted about this before, and he was kind of fascinated with it. But Alistair took that kind of same approach in terms of looking at people basically, you know, the whole, and you would get sometimes 45-minute consultations with a consultant who would then sit down, go through everything, get a piece of A4 paper out of his desk side. He would start writing down what it was you have, what medication, what that did. And this big joined up approach where people went out and they understood what they had, what to do about it, if that wasn't working, what to do then. And you could see, and you know, and I worked with this guy for 6 years, and I would estimate that probably 90% of the people who came in to see him who had manageable conditions like asthma never needed to come back, because they went out empowered with the information and the knowledge they had to self-manage, often when the management had been absolutely kind of chaotic before that, including A&E admissions with kind of in respiratory distress and stuff like that. And Alistair basically got me interested a lot in kind of evolutionary stuff and kind of coming from that cell biology background. And Louis and I often shared our interest in terms of that, So what is it can we change anything here? Or can we not change things here? Some things are mutable. And we both agreed on things and said, well, look, if you injure a tissue and looking at terms of tissue healing, and Louis got some lovely sections in the book about, muscle pain, muscle healing. And the example he and I would often give is, skin, because it's very, very visible and patients can see it. And the timeline of kind of tissue healing with skin, can we change that timeline? Well, we can't change that. So why would we want to try and do electrotherapy to it or try and do something else? Because if we could change that, that would be supernatural. It would be outside of the laws of biology, and nobody ain't done that yet. We might be able, because we can augment things, we can put things in place that facilitate that, maximize it. So it's that, are we best spending our energy doing that, or are we best spending our energy doing things that we can change? Which would be things like neuroplasticity, including cortical changes, including basically improving people's, confidence and movement.
Yeah.
And,
these are all pain things, aren't they? These are all mechanisms or conceptualizations of what's happening within the pain thing, rather than what's happening within the sort of tissue healing biology.
Yeah. And can we give people, evolutionary education and biological information about pain? Can we change that understanding that basically hurt does not equal harm? Not always. Pain is a liar when it comes to telling us the truth about the state of the tissues, because sometimes the tissues can be fine, but we still got pain. And sometimes the tissues aren't fine,
That makes me ask the question, is pain a liar, or just have we attributed too much responsibility to the experience of pain as a communicator of tissue damage? Is it actually that we just have misunderstood it?
Possibly, Laura. And do we teach that in Western medicine? Do we try and get rid of pain all of the time, at all costs, doing everything because it's abnormal, and then that creates more disquiet and more worry? And that, going back to saying about pain before, Louis said, look, used to say, don't get too worried about the pain. If you can change it and improve it, great. If not, continue with this, because that's going to improve the function. And most of the time, provided that there isn't any higher levels of threat, that functional improvement will gradually start to drive reductions in pain and a downgrading of the importance of that in a system.
Yeah.
And he used to say, and as I say all the time, it's very, very hard for the brain to continue to produce pain in an environment where tissues are basically inputting healthful information.
Yeah.
Hey, we're moving a load better down here, brain, okay, brilliant. Let's turn the pain volume down. We don't need to protect that area as much. It's getting back to normal.
Yeah.
Just empowering people with that. Had an interesting conversation with them one day, because I think I was probably having a bad week and I was a bit exasperated, and we were having a kind of chat. And I said to him, do you ever feel as though you spend a lot of time giving people permission to move? And he just said, all the time, Steve.
Yeah.
All the time.
Yeah.
Because that's what we do, isn't it? We give people permission to move, and that sounds very patriarchal. I don't mean it like that, but people are genuinely frightened to move. So can we give them some information? Going back to the hunter-gatherer thing, what would you do if you lived in the middle of the Amazon jungle? If those people, their leg didn't fall off when they had to get moved. What do wild animals do? How do they behave? They might go to ground for 24, 40 hours, but they've got to get up and start to try and find something to eat and drink. And it's that
flexibility thinking, isn't it? Sort of like thinking a bit outside of, the rule that you've created, or that is created by the social norms. Can we just start to branch out of that a little bit? And by doing so, does something change in the person's experience?
What's the evolutionary blueprint? That was something we used to, look at and ask a lot. What is the blueprint? What's evolution to do there? Human beings haven't changed genetically roughly about 100,000 years. So what is that blueprint driving us to do? Again, this adaptive thinking of, Louis was big. Is it adaptive? Is it maladaptive? Because we get into that an awful lot, don't we? In terms of that, inflammation. Well, we whip off, we get our colds, our flus, our viruses, or we have our bumps, our bangs, our cuts, our bruises. We get inflammation. We whip off, and let's get the non-steroids. So we've got the ibuprofen, the diclofenac, and the naproxen out. But that inflammation's adaptive.
Yeah.
It's signaling the cells to move into that area to repair it. So do we want to blockade it? We might do if somebody's stuck in bed with horrendous pain and they're then at risk of going on to develop a more kind of chronic back problem. Well, then we can maybe sacrifice a little bit of tissue healing to control the pain. So this is where the therapy decisions and the reasoning kind of comes in much more. Do we adaptively want to do this? Or if this person's managing, well, let's just keep them off the non-steroidals and just let these tissues basically start to heal.
You're right, and I think largely, I mean, thinking about my own cohort of physio, I graduated 11, 12 years ago. We were already, that message had already come through to us that, actually what we don't want to do is we don't want to get in the way of what is like evolutionarily beneficial biological processes. We want to create and facilitate like the optimal environments for this person to recover or rehabilitate. And I think that was the really interesting thing in Louis' writing, even from very early on, was that he really prioritized the word rehabilitation over treatment. Right. So for Louis, what I always understood from him was that, as far as he was concerned, physiotherapists were experts in rehabilitation. And that sometimes means we need to be able to treat tissues, but most of the time it means we need to see the big picture and trust that the tissue the healing process is a biologically predetermined process. And sometimes it might be that we opt for something that might slow that down because, well, we trust that the process is going to happen because it's going to help the person rehabilitate forwards. And it's being able to make those flexible decisions, isn't it, that I think is quite difficult for us when we get taught such a black and white picture of physiotherapy and pain and damage.
And it's kind of great to hear that from you, because if you were taught that 11 years ago, and I know, and it's a little while now, obviously with COVID the last few years, but basically it's a little while now since basically I kind of have been in a situation to kind of ask this in conferences and stuff, but basically we go out and ask people in the audience, as often students, how familiar are you with this pain biology? And we would often get a lot of very, very varied and different responses, because some people were very aware of it and some people not at all. Some people say, oh no, we haven't heard this at all. And so there was this quite big disparity in terms of the pain biology and how it was being taught, depending on where it was being taught as well.
I think that still exists even to this day. You talk.
Yeah, I'm sure it does. Yeah,
early career physios and late career. I mean, across the whole spectrum of physiotherapy. And I'm, thinking about this the other day, like this divisive argument behind, whether we do manual therapy or whether we don't do manual therapy is all based on where are we up to in our understanding of the biology and the bigger picture. And I think that's what Louis' introduction of the evolutionary perspective did for me. It was, and he talks about here like the evolutionary question versus the scientific question. So in evolutionary questioning, the person would always be driven to ask, well, why has this experience, this ability to think in this way, or this ability to communicate in this way, or this ability to act in this way, or this ability for the biology to process in this way, why has that happened? What is the benefit to the species for this to be an option? And then like the scientific question might be, well, how does that happen? How does that work? What is the actual processes that are happening? What cells are moving from one side to another or affecting another cell, things like that. And I remember just thinking, wow, we really don't ask that question very often. In physio, it's more, and it was lovely to have a word for that, like proximal reasoning, this sort of like linear reasoning that physiotherapists are routinely taught. So this happens here, therefore this is the proximal result of this process or this thing that happens. And I think he does that really well. And
as as Louis used to say, both used to say, look, if physiotherapists in traditional training, if we'd been electricians, we would only have ever wired circuits up in series, one after another. That, like you say, that level of reasoning, when actual human beings work within parallel processing all of the time.
And now it's dynamic complex systems theory, right?
Absolutely, and predictive processing, and Bayes theorems, and absolutely, and a lot of mileage in that. And it's but from that perspective, and looking at it from an evolutionary perspective, it's just it really, the whole time he was kind of always asking, why is that the case? Because what I think one of the remarkable things about Louis is, and there was a lovely book published by Mark Jones, an Australian physiotherapist, years ago, on clinical reasoning, and Louis had a chapter in that book, and I don't want to be disparaging to anybody else who wrote chapters in that book, but he's the only one in that book who explained why he's thinking what he's thinking. Yeah. And that's a difficult thing to do, because it opens you up, and then people ask questions. But Louis liked that. He used to say, ask me questions, because he wanted to think more about it. And then we used to do it all the time, test it. Well, what about that? And what about that? So it's okay to say what you're thinking. Well, I think it's that. Well, why are you thinking that? What are the reasons behind that? And evolutionary reasoning came into it an awful lot with Louis, in terms of his ability to kind of clinically reason that. And also that, as we used to say, the science is great, but can it help our patients? Is there anything useful here? Sometimes it's just interesting, and it doesn't kind of transfer through to a clinical situation, and sometimes it does. So can we use this to kind of help our patients, to help the people we see?
Yeah, absolutely. I think that's one of the reasons why I think things like philosophy, if we look to philosophers and to people like Louis as well, and people like yourself and like Mick, who are constantly saying, this is what I think it is, and this is the position that I take on even just on the jargon. Like, you think about, like, well, what is biomedicalism? What do we mean by that? What do we mean by reductionism? What do we mean? Like, what is the perspective through which we're looking at this problem, so that other people can gain access to, and gives them an opportunity for empathic listening, right? As well, that we don't often get very often anymore, I think, or there isn't space for it so much, especially as, like, things like presentations and talks. Like, I've just been asked to do a talk, and I get 5 minutes to set up my stall. The time frames are just coming down all the time. What can you develop in that short space of time?
Because the world's becoming built on sound bites, Laura, isn't it? And it's how do you explain that? It's why I'm not a massive fan of things like Twitter.
Don't be talking bad about Twitter.
But I use Twitter, and I think Twitter's great to share links and information. But how do you discuss complex subjects on Twitter with your word limit, and stuff like that? And it ends up and it gets lost, doesn't it? And it's difficult. But people like, I like Twitter because there's some great stuff come through. Oh, great, this institution's released this bit of research. I'll have a look at that. Great for that sort of thing. But it is difficult. And the problem is, we see it, and I see physiotherapy. I don't know what it's like in Holland, but we see physio here, and I've been in private practice, same as Louis. It's a very, very similar background. We both basically were private practitioners, both got small clinics, deliberately stayed small, because we wanted to become physiotherapists. We didn't want to be managers. We didn't want huge amounts of clinics to manage and stuff. The bit that we like is to be in there with patients to help. And but physiotherapy in the UK now, certainly in private practice, has gone to this like big business model where everybody wants to become huge, and it's shorter amounts of time. How do we explain this to people in shorter amounts of time? We can't. And so we've got to take that, and as the science expands and gets bigger and bigger, as Patrick Wall, who was a great, evolutionary thinker as well, Pat Wall says, just see what happens when you come along for a more complicated answer for an already simple, accepted paradigm. People don't want to know. They don't want life to become more complicated. So trying to get people to change, and if you want a lovely Louis story, Louis worked with Pat Wall for a while in Pat's labs in London. And I remember Louis telling me, there was a week when there was huge amounts of stuff had come out around the world and in Pat's lab. And he said, we're tidying the lab up at the end of the week on a Friday afternoon. And he said, I kind of turned to Pat and said, Pat, I can't wait to get out there and tell the world about this. And he said, Pat just turned and smiled, and he said, good luck with that, Louis. Good luck with that one. And he said a few years later, he said, I knew exactly what he meant, because Pat had been trying to do it for years and years. And it's really difficult, because we are asking people to have to learn more complex biology, to integrate it within kind of treatment plans and treatment programs. And it's you're fighting a hard fight, but you're fighting from Louis' perspective and my perspective and Mick's perspective. You're fighting the good fight. It's the right fight because we really want to help people. We're going to have to get in there with this stuff and find out what's going on in their life. What is the social status?
Yeah.
What's been going on at home? And you can't, physio when I was when I was at university, I thought, well, I don't want to know anything from the neck. Oh, I just tell me about your knee. It's like, but we've got to integrate all of that stuff. And I think Louis was a lover of people, and he probably understood the human condition better than just about anybody else I've ever known, and understanding that ability to kind of reason in that. So he knew a lot, but sometimes you've got to know a lot to do a little bit. Sometimes it's knowing a lot to be able to stand back and not want a blanket bomb with every bit of electrotherapy or every bit of manual therapy that in terms of, and Louis wouldn't.
Fear response, isn't it? Sorry, I know I've interrupted, but that's a kind of fear response in the clinician, isn't it? When something comes up that feels hard to understand or complicated or brings up a lot of distress in the clinician and the person, then the reaction is to just throw everything at it to try and get it to go away. But actually having more understanding about the sort of the person as a whole, and I don't mean that just from an individual perspective, but what it is to be human and what it is to be as a mammal that has all of these potential experiences that we can coordinate across an individual body, but then also shared across society. Like being able to think in that way it sort of takes the fear away a little bit, and you realize that, okay, so we are actually subject to biological law, right? Although we don't have a unifying theory or unifying laws within biology, which is one of the problems, that each area of our physiology does seem to have its own time zone and its own time frame and its own way of working. We kind of have to be respectful and knowledgeable of that. Like, for example, if we're talking about neuropathy and we're talking about a 6-week turnaround in pain, I mean, that just doesn't make sense for the nervous tissue. But if we're talking about 12 weeks and more, then maybe that makes more sense. And having that recognition and that those you almost have to hold multiple models in your mind all the time, don't you? And that's what he's talking about in things like parallel processing, when he goes on to talk about the benefits that he learned. I think it was from the Maitland model, this sort of parallel thinking. And then I think that's really what he's bringing forwards in the shopping basket approach, which I really love. Can we talk about the shopping basket approach? So let me find it in my little book. So the shopping basket approach, if you haven't got the book out there, it's in section 4, and I'll show you a picture of it. I think I've got a picture of it somewhere, here it is. So this is it. This is the shopping basket approach. And I would really like to introduce the story about this a little bit, because I think Louis made it on purpose a little bit tongue-in-cheek, right?
Well, yeah, and I mean, it was that that gathering information. It was that going around and what is it that we can find? What skills have we developed as therapists to use? Because he felt that the skills that we had, if you'd come from a Maitland background or a Mackenzie or a Syriac type background as it was back then, what skills have we got, and can we then put them into useful compartments, shopping basket, and take those away and then use those basically to clinically reason. And it was, again, just trying to make it really, really simple in terms of the approach for that.
Yeah, I like the anarchical approach, though. It's this kind of like anti-brand, and it said somewhere in here, like, it was a reaction to something which drives me mad. The very term approach, the Maitland, the Mackenzie, the Kelton-Born, the muscle imbalance, and so on and on and on. And this idea, and he says, I hope I wonder if I've highlighted it somewhere, because he wrote it down. Oh yeah, here it is.
Which page are you on there, Laura?
I'm on 993, and he says he had this observation, like one thing I realized a long time ago is that how anyone reasons is hugely dictated by what they plan to do. The more biased and limited in your skills or knowledge, the more blinkered and limited your reasoning is going to be. And essentially, if it looks like a duck, if it looks like a nail, if you've only got a hammer, everything's a nail. That's it.
Yeah.
And I, and Louis was really quite brave in the sort of Mackenzie debate and the Mackenzie discussion. Like really put his, I suppose,
he got so much flack for that. He really did. Yeah.
And if you haven't read the Mackenzie debate, Louis' blog, Aches and Pains, Gifford's Aches and Pains, I think it's Gifford's Aches and Pains, isn't it? Gifford's
Aches and Pains. Yeah,
it's still up on the website, and actually that's where you can buy the book from if you buy it directly from there. And you can see the whole Mackenzie debate where he really highlights the potential for like driving fear avoidance and the limited clinical reasoning perspective that not people who use Mackenzie, but Mackenzie zealots might use. So obviously, like what we're not saying, and I think Mackenzie doesn't own extension, and I think that's been an argument for a while, right? We're just talking about movement a lot of the time, and to use that as a reasoning process might be helpful sometimes, but to only use that is the problem.
Yeah, absolutely. And it's exactly the same with every approach, isn't it? You're looking to, because in physio for years and years, we kind of we like kind of systems to do things, don't we? We like to kind of look, if you find A and B, do C. And it's this process of system of kind of hunting out these things that we're looking for before, we're not kind of finding them, we're kind of trying to seek out. And what he saw was the shortfalls in all of those systems. Like, it's like everything else. It's like, going back to the days of things like Mackenzie, Maitland. But Louis was the first to say, look, there's loads of great stuff come out of that. And we learned some great skills in terms of basically handling and examining and looking for range of movement and looking for strength and stuff. But in terms of the theories behind them, then essentially that was more the kind of the flaws in those processes. The same as with sacroiliac joint and stuff like that. And Louis and I discussed this many times. You're going to find positive stalk tests and you'll find this and that, but we find them on everybody else who hasn't got that stuff as well, And then sometimes, and coming from a manual therapy background, I was obsessed with the sacroiliac joint, spent 10 years studying it,
my goodness.
Used to teach mechanical courses on it. Hands up, and I often I often say to people, look, if you did one of the courses on the sacroiliac joint, sorry, we got it wrong. And the more that we studied it, the more that I studied, the more I realized that it couldn't be causing these problems, and it wasn't. But and as soon as I stopped looking for it, I've never seen a one since. I might have seen some with inflammatory arthropathy. So, but you'll find it if you're looking for it.
Yeah.
And this is the great difference. And this is what he was trying to get out. And get away from with the shopping basket approach. Look, don't try and make it fit the diagnosis. Just see what you've got. And work at that, address the problems that patients come to you with that are telling you that they've got, that you're finding from your clinical examination with the skills that you already have. Because as Louis was a believer of, you are the best person to do this, actually, feel confident about that and do that. And try and really to make people not afraid of pain. Clinicians to be not afraid of pain. Because lots of clinicians are sometimes afraid of pain. And then if patients report more pain, then clinicians, like you said, they kind of sometimes go into a little bit of panic and do that. Or the classic, of patients coming in and saying, my doctor said, or my therapist said, it was so bad, they didn't even want to touch me. You think, how bad must the patient think it is if the clinician or the medical practitioner didn't want to touch them? And I think what Louis wanted to be was, he wanted people to be not afraid of pain and not afraid to go and gently and mindfully examine patients, knowing that they weren't going to break them, they weren't going to harm them if they did this stuff, and they could use these skills, and not be afraid to actually go in there and very gently and kind of reassuringly kind of help these people start to understand that. And by that, assess all of these things and put it into those shopping baskets and make that thing. But also his other thing that didn't get, and I can't remember if he mentions it in the book, but a brilliant thing that, to talk about pink flags. So because he said that we're really great at telling everybody what's wrong, we sometimes forget to tell people what's right. And that makes a massive difference, because 90% of things, great. And Louis and I were, again, huge believers in, and they still go through, reflexes were perfect, your power's great, you've got great movement, and all of that stuff, just to make sure that people realize that, when they go out, they're not absolutely wrecked. And it's one small thing, that basically is, it's come up in an examination. But trying to have a kind of logical criteria. But you're right, not wanting to call it the Gifford approach or something, of which you would have been absolutely horrified.
And I think what this answers so many questions, right? So I get this quite a lot, because people consider me a psychosocial physiotherapist, which means I don't touch people, I'm not interested in biology, blah 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 blah. And anybody that knows me, I hope, would walk away thinking that is not the case, that I'm not a psychosocial physio. I just invest in understanding psychological models because I think they're helpful. But the shopping basket approach really answers that question of, well, where does the bio fit? How do we know what to assess and what not to assess? Well, Louis is really clear. Like, we have a due diligence that we must perform, effective, testing and screening for things that might be masquerading or that might not be belonging in our clinic. And that has a huge place within our shopping basket. It comes under that biomedical model, where we're actually thinking, does the biomedical science that's teaching us about, what's happening within the physiology and what's happening within disease and pathology, is that helpful in this situation? Does that apply? Yeah. And does it help me to understand what's happening with this person, as much as the psychosocial issues? And, things like, high levels of depression, high levels of distress, high levels of anxiety. These are just as much a serious screening of a red flag as anything else. And we need to be able to see when this is beyond what we can deal with, and within what we can deal with, and using this shopping basket approach, which I just love, because I love how anti-serious it is, like how anti like ego it is, and ultimately thinking, okay, so if we can't affect, like you said, we're saying earlier, if we can't affect some of those things, what can we change that would ease the suffering within this human, within this person? And that's where all those disability models can be very useful.
Absolutely. And you're absolutely right. And that's exactly the message that Louis, you would have loved to have heard you say that, because that's exactly what he wants. Yeah. Sometimes the biomedicine is important, because we might assess people, but what we've got to remember is that sometimes people with lots of yellow flags, they get cancer too.
Yeah.
And there might be red flags in there as well.
In fact, often missed in people who are considered
absolutely,
complex or chronic pain. In fact, in the world of chronic pain, when you're working with people, actually what you see is people who've been through loads of clinicians, but because they've been given the label chronic pain, the biomedical stuff gets devalued and lots of stuff gets missed. And that's really important, that we don't lose our vigilance just because we're working in this particular area.
Absolutely. And Louis, from that perspective, was very much, it is important to be good at the biomedical side of things too, and as well as the psychosocial side of things, but not get tied and become too passionate about that. And exactly as you alluded to there, Louis was accused loads back in around about the 1990s and 2000s, and then the same thing came with me. They said, oh, he's, it's all hands off, he's all hands off. Louis did loads of hands-on treatments. He still used manual therapy, right up until the end of his life. He still used manual therapy, but he used it in a way where the reasoning behind that was radically different to the way that people had been taught. And he didn't use it with everybody because it wasn't appropriate, but using that reasoning. So again, what can manual therapy do and what can it not do? And how can I move this person forward? How can we actually kind of change things here and facilitate some change in this person, and using it in a way, in terms of looking at that, rather than actually kind of then trying to find the diagnosis that takes you to the manual therapy.
Absolutely. I almost, so like, when I say an anti-protocol, I don't mean anti-guideline. So guidelines and protocols obviously are two totally different things. Guidelines are produced by the specialists in that area looking at the research, but protocols are often established locally within a particular, might be a particular hospital has its own protocol for this particular thing. And I think we can be cynical and questioning of some of those. and it's almost anti-protocol, which I think Louis would have been really happy to see some of the changes that are happening in things like psychology-based approaches, with moving towards process-based and away from traditional CBT and protocolized approaches, things like that. Because I think it's exactly what he was advocating for, but across allied health professions. And I wanted to talk, and you bringing us on there really nicely to how Louis conceptualizes graded exposure, because it is different to other models of graded exposure. So Louis really took almost like a CBT approach to graded exposure, this sort of behavioral experimentation, and allowing the person to, he talks about the Vlian and Linton approach and how to allow them to rate what it is that's getting in the way. And I think if you look at things like cognitive functional therapy, that's really what they're doing a lot of as well. And
so that so the nice little whiteboard, how do you feel about this? Confident, not so confident, no bloody way, mate,
that's not in the book, but that's
so and but again, really giving people basically empowerment in terms of them being involved wholly in the decision. And he would even do that with massage, as we both do. And if he was going to do something like massage, he would say, okay, this needs to be pleasant. And he would do graded exposure in massage. This needs to feel good. And he would give over that power to the patient so that it stopped any embarrassment of the patient lying on the plinth, disappearing, thinking, oh, this is really horrible, of which is, going to send everything through the roof usually, to say that, look, this needs to feel good. I'm going to use a pressure that I think is going to be reasonable here. But you tell me if you want me to work in a little bit more of an area, or you want me just to ease off. Great. Patient knows that they're in control then. And Louis was the same with graded exposure. Okay, look, how nice does this feel? So I want this to feel nice. This needs to feel kind of nice. So he was always very, very keen to get people into that zone of basically things feeling nice. And if it doesn't feel nice, okay, if it's uncomfortable, I want it to be a comfortable level of discomfort.
And meaningful, right?
And something that feels basically, if it's uncomfortable, it needs to feel like, well, that's that type of discomfort that you get when something's a bit stiff, but it's being moved and that feels a little bit better. But also, absolutely, exactly as you said, functionally specific whenever and wherever possible. So rather than kind of, maybe lying down on all fours doing a transversus exercise, can he get somebody to go from sit to stand? Can he then start to reduce the level of the seat height so that it's then working then further down into basically, into more lumbar flexion, into more flexion of the knees and working from there. And then can he kind of start to move it up from those positions and looking at easy starting positions. Where is the starting position that's comfortable, and changing those and being prepared to change all of that stuff all of the way through. And just finding positions and novel positions for people sometimes to start to move in, but whenever possible, trying to actually make that function specific to the things that they need to get back to doing in their life. And I think, again, we sometimes overlook a lot of that stuff from a rehab perspective. But he was really, really functionally specific with that graded exposure. Let's do a few of those. How does that feel? All right. How many of those do you think you could do comfortably? Oh, I think I could do 10. Let's start with 50%. Let's do 5 to begin with. So that's kind of where Louis was coming from with that, rather than a lot of the other kind of things like SMART principles where, you get people to try and do them and then you'll take an average of the last sort of 3 sessions and stuff like that. Louis wanted to be getting in there straight away and getting people confident to move straight away. He didn't want them to maybe stir themselves up by doing a few too many reps tomorrow. So how many can you do today? Getting them to do them there and then in the clinic, and looking at that person's face when they're doing it. Because they might be bending forward, but it might look like that, or it might look like that. And it was like, okay, how are they kind of responding to this as well?
And what's driving them, and why are they doing it? Are they just trying to be good patients? And understandable when we have a system where we almost tell people, if you do exactly what we say, you will be rewarded with recovery. And actually, that's not how recovery works. It's part of your human and societal and biological processing, and we're just trying to optimize that. And I thought if anybody is interested in thinking about a sort of behavioral approach to behavior, like experimenting in clinic with patients, on page 899, So section 2, they're talking about the Vlian and Linton section. There's a really, really nice breakdown there about behavioral experiments and how to create contracting between clinician and client. Well, what do you think would be a height that would set all this off? Okay, well, what do you think you can achieve? Well, let's try and figure that out. And a little bit of undermining and questioning and being curious, and having these exposure to the thing, and seeing what happens. And I think that's a really nice section there if anyone's interested in that. And it really, Louis says, the idea is to succeed, not to fail. We want to find small challenges that are challenging enough for the person. And when I say person, I don't just mean the cognitive person, but the person's physiology to be interested in wanting to problem solve that. That's that novelty, isn't it? People need small, achievable challenges that they can work on and try to solve, but with the payoff of succeeding, that sort of biological reward that I succeeded. Yeah.
So absolutely, and it's got to have that. There's got to be that degree of reward at the end of it, hasn't it? It's got to be taking you towards that basically task that you want to do or thing that you want to get back involved in. And it's got to be fun. Louis would get down on the floor, he would dance with people, he would do dance steps, and he would get down there, he was doing this stuff, well, what about this, and move like that, and if I don't, and so he's always looking for ways, but trying to keep it specific, but also trying to have that element. He was a big believer in, making friends with patients. Said you've got to make friends with patients, because if they don't like it, it's really hard to kind of move people on, and not friends as in let's go down the pub tonight, but basically, but to get on the wavelength of that person, be interested and be, and I think that only comes, and I've written about this before, but I think kind of empathy is a kind of natural thing. I don't think we can teach it. We can maybe augment it, but you either or you want. I think so we come across those people, and I think when we talk about therapists and maybe good therapists and not so good therapists, I think that's probably the big difference, is that we've got these people who, maybe Louis is a prime example, who was naturally empathic, naturally interested in people, high levels of knowledge in terms of that, and all of that together, and then that's probably what separates those people out in terms of their skills in, as a therapist, if you like.
Maybe I'm going to come in there though, because I think that I could. Sorry, and I'm terrible for interrupting me.
Challenge it if you like.
But I would say that equally, like what you said earlier is that don't we just feel like we spend a lot of time giving people permission to move? As someone like I work quite a lot with individual clinicians and groups of clinicians, and then I also consult in pain departments and how to change their therapy and their service delivery. I spend a lot of my time giving people permission to like their patients, to connect with them, to feel humanly, and like collaborate, and to come down from that paternalistic, like little platform that we put ourselves up on. And I think there's something in that as well, that lots of clinicians are told that they're not allowed to be, because of this professional identity, this professional boundary, which gets mixed up with like empathic boundary. I think, although I do think you're right, I wonder about whether we can teach empathy. I think it probably functions more like compassion, where we can't teach compassion, we have to give it space to grow. And I think something in permission and taking the empathy that they have in their normal lives with their family and friends, and allowing that to flourish and spread into their clinical practice, there's a real need for that step, for somebody to say, yes, this is your scope of practice, you're allowed to do that.
Absolutely. And it's difficult though, isn't it, because there is that there has still got to be that kind of, there's got to be a therapeutic alliance, but there's got to be that line between the kind of clinician and the patient. So maybe that's not such an easy thing maybe for some people to develop in the way that maybe kind of Louis developed it.
Because, I think that's a big point. That's a big difference.
Because he believed in having a joke and having a laugh with patients and making them comfortable, and but ultimately they got a thoroughly professional assessment by a consummate clinician. But they did it, and I used to laugh because you would have these lovely ladies going in their 80s and stuff, going to see that lovely Louis. I go to see that lovely Louis in the clinic. Not an idea of what his background was and think, because he was just lovely Louis, and he was, and he was. But the level of stuff that they kind of got, from him, was just phenomenal. But in his lovely little clinic, next to his house down near Falmouth, and people go in and see him, and and it really just had that ability in terms of just understanding the human condition and coming onto people's wavelengths. And it's that ability, I think, isn't it, to kind of to shift to where that person's at their level of understanding, at their level of function. What is it they want to do? What is it that excites them? What are they going to want to do? What's going to be interesting for them? What's not going to be interesting for them? And working on that, it's hard, isn't it? We do a hard job, don't we?
Yeah, hard.
Tough, isn't it?
Really hard. And I think, having the ability not only to do that, but to write it all down, to help other people to do that, that's a real skill that is admirable, that I think is aspirational. Like that's the dream of, for many of us, to be able to achieve that kind of level of being able to support other people. And I think I really think that this should be a necessary reading for clinicians, not just physios, because although it is very specific to physio, but it is translatable, and it could be, I think it's a really beautiful place to end on, because actually what you do see in these books is exactly that: lovely Louis and this consummate professional all in one, someone that takes their job very seriously but themselves not so much. And that's the link, isn't it? That's what helps us to connect. Yeah,
absolutely. And Louis just wanted to help. He wanted to help other clinicians. He wanted to help patients, and he was keen for other people to know this stuff, passionate about that, getting this knowledge out there to make life easier, because he'd burnt out. He spent a while working on a building site and thought, this physio stuff just ain't working, and kind of got out there and had those sort of doubts and stuff. And he kind of knew what that felt like, and he didn't want other people to go down that route. Can we reduce kind of therapist burnout? Can we take that away?
Absolutely.
And he had an ability to kind of communicate that was kind of, I don't know if I'll ever come across it again. He was one of the most brilliant people that I've ever worked with, and I've had the pleasure of working with other brilliant people like Alistair Bruce I mentioned before. Incredibly fortunate from my perspective to have ever encountered two people like that, one alone. But amazing thinker, amazing person, and an amazing human being. And anybody would tell you who know Mick would tell you the same thing. To know him as a person was even kind of richer than to know him professionally, because he was just the best. He was the funniest guy. He had the brain of a comedian, the brain of a rocket scientist. And it was all rolled into one. And he just loved life. He just absolutely loved life. But he wanted to kind of share that, and he wanted to help people, to help others, and did it in a way without any ego, which is really rare. Really rare.
And that's what you hear about him from everyone that's known him. And sadly, unfortunately, we lost Louis, but we managed, before he left us, he did give us this beautiful book, and almost like a guidebook to transitioning and moving into biopsychosocial physiotherapy. And of course, like this, things have moved on. There are things that could be added to Louis' method now, and things that maybe, I think sometimes there is a tendency to and I think, think that we're still where we were, but actually clinically, when you talk to early career clinicians now, they've got a lot of this is being brought into their undergraduate work now. And I think there's a lot of hope for this transition that started, way back when, that it is starting to happen. And I think that's really lovely. And to anybody that is watching this either live or is watching this back on record, if you've enjoyed Louis' book, if you've enjoyed these talks, please do consider going to Prostate Cancer UK and giving a small donation in memory of Louis, really.
Yeah, that's a lovely gesture, Laura. And Louis and Louis' family, for a number of years when Louis was alive, we used to do Movember every year and grow the daft mustaches and stuff like that. And Louis got a lot from those organizations, basically, in his kind of journey with the prostate cancer, and again, in himself, remarkable guy who had a diagnosis of terminal cancer, was told probably a year to 18 months and lasted 6, and was still running running half marathons 6 months before he died and skiing down slopes in North America. And as he said to me, just going to ignore it, Steve. I'm not in denial. I know it's going to get me, but I'm not going to sit around and wait for it. I'm going to live my life. And that's what he did. And he got back into the writing and did the books. And that was Louis, and he dealt with the disease the same way that he dealt with everything else in life, and really remarkable. And if you really wanted something just to end, that was the epitome of Louis. We were talking about, excuse me, Laura, I'm getting a little bit emotional here.
That's okay.
We were talking about the books, and he was giving me a little bit of feedback. Well, I was giving him some feedback when he was down in a hospice in Cornwall just before he died.
Yeah.
But his pain got quite bad just towards the end of his life, so he was in there really for kind of pain control. And I phoned him up this day, and he was really complaining because he said, I'm whacked out my fucking brain on this morphine, Steve. So he wasn't thinking. So I was filling the gaps in for him a little bit about stuff that he'd sent me about the book, and then kind of going back. But the first 5 minutes of the conversation, all he did was tell me how lovely all of the staff were in the hospice. Taking such good care of me here, Steve. They're so lovely, these people. And that was Louis. That was absolutely Louis.
Yeah, that's lovely. And thank you so much for offering your time and your stories and your memories. And it's hard to talk about someone who you love that you've lost in a public way. So thank you so much for agreeing to share that with us, because for many of us, we've never had those experiences of him. And if it means that more people go out and buy his book and get connection to the message and connection to the things that you and Louis were working on for such a long time, then that would be a great outcome.
Yeah. And he would, exactly as you said there towards the end, in terms of things that change, Louis would embrace that. And what he would say to people is, look, embrace the change.
Yeah.
Don't get fixed on anything. Embrace the change. If things come up, look at them, look at the evidence, look at who's done it, and scrutinize all that stuff, because he wanted change, he embraced it. And I think that's what we need to do as clinicians. If we're going to get really good, we don't want to get stuck there. We want things to change. It's going to keep us moving forward all the time. Okay. Keep talking, keep basically joining clubs like yours, Laura, and thanks for asking me to do this today. It's a real privilege. It's always a privilege to talk about Louis, an absolute privilege to talk about him kind of as a friend. And I managed to do fairly well there, because it's a wonder the tears didn't come actually probably earlier on.
Yeah.
So I sometimes struggle to get the end of some conversations with him, but it's like everybody else who knew him. Mick would be exactly the same. It hurts. But basically, but whenever we think about Louis, and I'm sure Mick would absolutely echo this, you smile, because that's basically that's the memories that he leaves you with, and that was Louis.
Yeah. And on that note, let's bring this to an end. So thank you very much again, Steve, and thank you to everybody that joined us live and to everybody that watches this back on the recording. This is the Pain Geeks book club, which we do every month, and we're just bringing the series of Aches and Pains to an end, and we'll be moving into our next book, which is the book by Pat Wall. And obviously I haven't written it down and now I've forgotten it. It's The Science of Suffering, Pain, the Science of Suffering. So we'll be doing that next. And then we'll be moving on from there, probably, I don't know actually. So I will keep that in mind. So next book will be Pat Wall's The Science of Suffering, and we'll be discussing that at the end of April. What are we, end of April now? Let's say something like the end of May, middle of June. Okay, so if you haven't signed up to Pain Geeks, please do go to that's how you know how old I am, because I still say all the W's, laurarathbone.com, and look up Pain Geeks. It's a small subscription, and then we can have more chats like this and keep growing our practice together as a community. And so thank you very much for your time. Thank you very much for all your energy and your investment in this, and see you next time. Thank you. Bye.